I know you enjoyed the presentations from this morning. They were really just a show of excellence, and I appreciated the topics, and I hope you did too. Well, this afternoon, we're going to have three excellent speakers. Dr. Ferdinand, who is going to be speaking to us on advances in hypertension control and new concepts and approaches. Dr. Ferdinand is the Gerald S. Berenson Endowed Chair in Preventive Cardiology, Professor of Medicine at Tulane University School of Medicine. Following Dr. Ferdinand, who is joining us by Zoom, we will have Dr. Pardo. Dr. Pardo is an assistant professor at Weill Cornell Medicine, medical director of the Women's Health Practice and New York Presbyterian and Ambulatory Care Network. Dr. Pardo will join us on the panels once Dr. Ferdinand is done, and then lastly, speaking on uterine myomas will be Dr. Slimy, who is co-founder and executive director and surgical director of the International Medical Response Foundation. So thank you all for joining, and we will lead right into Dr. Ferdinand.
Thank you very much. I'll try to move along quite briskly so we will have time to have a panel discussion, questions and answers. Let's go to the next slide. You moved through all of the slides. Let's go back to the beginning. All right, stop there. Okay, this is a bill, so each of these will fly in. I'm going to review the impact of uncontrolled hypertension in diverse populations. Next, I will talk about best practices for clinical care. You can click, it'll build. Next, I will update the new blood pressure goals and patient-centered approaches. And then finally, implementation of best practices. Click each of those, it'll move along. One of the things that you'll note is that cardiovascular disease has had an uptick. Some of this is due to the pandemic where people lost contact, if you can click, with their primary care clinicians. So you have a lot of risk factors that got worse, and the manifestation of that is an actual increase in mortality rates recently. Next slide. Keep clicking. Next slide. Now we know that cardiovascular disease, heart attack, strokes is primarily due to how we live, work, and play. If you look at the modifiable risk factors, however, this is from the global panelists looking across the world, the most powerful and prevalent of the risk factors is an elevation of systolic blood pressure, even more than simply BMI, LDL cholesterol, smoking, or diabetes. Next slide. The red line is the linear relationship on the x-axis, reduction in systolic blood pressure, and on the y-axis, cardiovascular events. So you see that there's a downward trend such that lower is better. Next slide. The click goes to the SPRINT trial, which was a major NIH trial, over 9,000 patients, and it led to the 2017 high blood pressure guideline that suggested that the goal is now less than 130 over 80. It's no longer 140 over 90. And that's because in SPRINT, they targeted a systolic blood pressure of 120 and showed getting a more intensive blood pressure reduction decreases heart attack, strokes, cardiovascular mortality, and overall mortality. Click one more time. There have been a series of recent studies, STEP, ESPRIT, and BP Road, done out of China, that continue to show that regardless of whether a person has diabetes, whether they're high risk, whether they're even over the age of 75, decreasing blood pressure intensively lowers cardiovascular events. Next slide. These colored populations are the various populations in the United States, and I use this slide to depict several things. One is, click, you see that awareness and treatment are actually fairly high, so it's no longer just enough for us to do blood pressure screenings. Where we fall down, click again, please. is in control across all the various populations. And if you look at the population that's defined as non-Hispanic Black, it has the worst levels of control. So people know they have high blood pressure, they often are getting treatment, but it's where we have control as the problem. Next slide. Next slide. The top dotted lines are heart failure mortality. Now, I use mortality because it's something that's not debatable. This is not social science. And if you look across the x-axis, for decades, the top dotted line, click again, non-Hispanic Black or African Americans have the highest rates of heart failure-related mortalities. And this is primarily driven by poor control of blood pressure. Heart failure is one of the leading causes of admission in the Medicare population. In the younger population, it starts related to a poor control of hypertension. Next slide, click. And you see the highest rates, the top dotted line, Black or African American. And this has been going on for decades. Next slide. Another problem that we see as a target organ for uncontrolled hypertension is end-stage renal disease. That's the non-Hispanic Black or African American, only 13 to 14%, but almost a third of patients who are on end-stage renal disease dialysis are Black. And that's because of the disparate rates of blood pressure control. Next slide. There's a new risk calculator, you're going to hear more about this, in which we take various things, click, sex, age, blood pressure, kidney function, cholesterol levels, and we get an assessment of a person's risk. At around 11 o'clock on the dial, you see SDOH, that's the social determinants of health, where people work, live, play, and pray. The new risk calculator is going to request that we put in the zip code because we know that the zip code is a powerful predictor of risk along with the other conventional risk factors. Next slide. And if we look at the various populations across the United States, uninsured status leads to poor blood pressure control and bad outcomes. And it varies across the various subpopulations. One of the problems that we're going to have is that if we restrict Medicaid—
Recording in progress.
And we restrict the Affordable Care Act, you're going to have more patients who have uncontrolled hypertension, and they're going to have worse outcomes. Next slide. This concept of the social determinants of health is not just a term of art. It has a real impact. On the left-hand side, you see the hospital. This is where people go to get care. This particular concept of the revolving door is from a paper that I was part of the working group. And what we suggested is patients leave the hospital, then they go into adverse social determinants of health, financial hardship, high co-pays, food deserts and food swamps, disadvantaged residential environment, and then return back to the hospital. So you can see that simply treating patients in the emergency department or even in the clinic is not going to be adequate if we don't address these social determinants. And I think having an uninsured patient is a cocktail for disaster. Next slide. The last guideline in the United States is actually from 2017. We may have new guidelines in the future, but the last guideline from the American College of Cardiology, American Heart Association, and multi societies is where we have the present recommendations on treating blood pressure. Next slide. That is where the definition came that hypertension now starts at 130/80. The idea is not to give patients diseases that they don't have. But if you can remember that regression line, lower is better. And based on the SPRINT trial, and now even on some trials coming out of China, intensively lowering blood pressure with a goal of 120 is better than waiting for 140/90. In fact, if we wait for 140/90, it's now defined as stage 2 hypertension with an increased risk for heart attacks and strokes. Next slide. Next slide. This is the algorithm from the guideline, and in the interest of time, I'm not going to go into great detail. I just put a red box around stage 2 hypertension. What we used to call the start of hypertension 140/90 is now considered stage 2. And what the red box says is, along with lifestyle, non-pharmacologic therapy, these patients will need blood pressure medications. Medications are not bad. Medications are good when used appropriately. Next slide. Next slide. Next slide. Which drugs to use? Well, there are over 125 antihypertensive agents, but the ones that appear now to be most effective are at the top: the thiazide type diuretic, and if the patient has kidney disease, loop diuretics, furosemide, torsemide. The long-acting calcium channel blockers, not short-acting, but long-acting. I preferably like amlodipine. It tends to have a really long half-life. Even if the patient misses a dose, it remains effective. And then the combination of either an ACE inhibitor, such as lisinopril, or an angiotensin receptor blocker, such as losartan, olmesartan. Next slide. So these cocktails of medications, often giving 2 medicines in 1 pill, is going to be needed for many of these high-risk patients. Next slide. And in some patients, they're going to need 2 or more medications. The colored bars are some of the outcome study in which we look at how to decrease heart attack, strokes, and kidney disease. The names of the studies are not as important as what the red line shows. In these large outcomes trials, in order to protect against some of the ravages of hypertension, it's not 1 or 2, it's often 2, 3, or even 4 medications. So what we ask our patients to do is understand that the trials have been done. I don't want my patients to be in a placebo trial. The trials have been shown that 2 or even 3 medications in these high-risk patients will be needed to prevent the ravages of heart failure, heart attack, strokes, and end-stage renal disease. Next slide. This is directly from the 2017 high blood pressure guideline. As I mentioned, we're going to have new guidelines perhaps in the near future. But what they suggest is for these patients who have high blood pressure, it's going to be 2 or more antihypertensive medicines to achieve a target now of less than 1/3/80. This is for most adults, but it's especially true in Black adults who often have more severe and difficult to treat hypertension. Next slide. Now, there is a term of art also called resistant hypertension. These are patients whose blood pressure remains greater than 1/3/80 despite being on 3 or more medicines at optimally tolerated doses. And this particular algorithm from the American Heart Association suggests how we should approach these patients who have resistant hypertension. Next slide. First of all, you want to make sure that they're getting an exclusion of secondary causes. These are things that may be causing their hypertension, such as pheochromocytoma, aldosteronism, renal artery stenosis. And you want to make sure that the patient is adhering. Next slide. Regardless of whether or not the patient has resistant hypertension, you also want to maximize what we call therapeutic lifestyle interventions. That means that you want to ensure the patient's getting adequate sleep, that their dietary pattern does not include excessive sodium, an increase in potassium, which would mainly be the DASH type diet, appropriate weight loss, and physical activity. Next slide. And then finally, you're going to optimize those 3 drugs that I mentioned earlier. And that includes a RAS blocker, that's an angiotensin converting enzyme inhibitor, or an ARB, calcium channel blocker, and diuretic. Next slide. In some patients, they're going to even need more medications, but perhaps those 3, if used appropriately, will control the majority of people, even with resistant hypertension. Next slide. There's also in medicine a move now in those difficult to treat patients to consider another thiazide type diuretic. It's not hydrochlorothiazide, but chlorothalidone or indapamide, which may be more effective in patients with moderate kidney disease. Next slide. And in the very difficult to treat patients, we need to block the aldosterone effect, either with spironolactone or especially in middle-aged men who want to avoid erectile dysfunction or gynecomastia, eplerenone. Eplerenone is similar to spironolactone, but doesn't have those estrogen stimulation off-target effects. Next slide. When we look at populations, this is from the Regards trial in the Jackson Heart Study. Jackson, Mississippi, the Regards is in the South. And you look at patients who have treatment-resistant hypertension. The reality, next slide, is that most of them don't have ideal lifestyle. Next slide. Very few are using chlorthalidone or indapamide. Next slide. And less than 10% are using either spironolactone or eplerenone. So we should identify these patients who have poor control of blood pressure, address lifestyle, and use appropriate medications. And in many cases, that includes an aldosterone antagonist. Next slide. I mentioned several times the SPRINT trial. It was published in New England Journal of Medicine in 2015. It was a landmark trial, over 9,000 patients. Next slide. And what they showed in the SPRINT trial, the Kaplan-Meier survival curves separate. Intensive treatment in the orange decreases a composite of myocardial infarction, acute coronary syndrome, stroke, heart effect, heart failure, and death from cardiovascular diseases. Next slide. And one thing in the SPRINT trial, most people don't recognize this, is that the mortality benefit with intensive blood pressure reduction was shown. So death from any cause, again, the Kaplan-Meier survival curves separate. Intensive blood pressure treatment saves lives. Next slide. This is called a forest plot because it's like a tree limb. And you look at all the various subgroups in this large landmark trial. Next slide. You can see that to the left, intensive is better, whether the person's over 75. So this idea that aging is a natural process and blood pressure should be part of it, no, that's not true. We treat these patients intensively with care, of course. Next slide. We also treat them if they are male or female. Next slide. And even if the blood pressure is just a
Recording in progress.
We lost projecting the slides. She's going to go back to it. So I think the take home thus far is that blood pressure is the most powerful and prevalent of the cardiovascular risk factors, that intensive blood pressure saves lives, it reduces heart attacks, strokes, heart failure, and that it has a wide effect across a wide range of patients. Next slide. I mentioned the Chinese studies. This one is a treatment of hypertension in older patients, published in the New England Journal of Medicine. Next slide. And similar to the SPRINT trial, it showed that in older patients, targeting blood pressures of 110 to 130 had a lower incidence of cardiovascular disease than the conventional means of treatment. Next slide. So regardless whether or not a person is 75 years of age, with care and caution, we should intensively lower blood pressure. Next slide. This is the results out of that large Chinese trial. You can see standard versus intensive. The total number is 9,000 patients, and they lowered blood pressures well under 130 millimeters of mercury. The 140/90 is important, but it's not enough. The standard treatment did not have the same benefit as more intensive treatment. Next slide. Next slide. This Kaplan-Meier survival curve you see separates, similar to what we saw in SPRINT, but remember these are in patients who are 75 years and older. The p-value is 0.007. So lowering blood pressure is important regardless of age. Next slide. Next slide. Here's another recent trial out of China. Again, they have these huge trials that they can do in China. This was just published last year. And it looked at lowering the blood pressure to a goal of even less than 120 versus 140, with or without diabetes. It's called the Esprit trial. Next slide. And it's going to show the same result, intensive blood pressure reduction, whether or not the patient has diabetes or previous stroke, targeting less than 120, reduces major vascular events, and there was only a minor excess risk. Next slide. Next slide. Here again, at the blood pressure, you can see how robustly they lowered the blood pressure. Let's keep going. Keep going. And a similar forest plot to the left, intensive being better. Next slide. Major cardiovascular events. Next slide. Death from any cause, and the primary outcome of combining cardiovascular events and death from any cause. Next slide. And a final recent trial published in November out of China looked specifically at patients with type 2 diabetes. At one point, we thought maybe there's not as much data on persons with diabetes, but this trial showed, again, huge, next slide, huge population, that intensively lowering blood pressure targeting 120 versus the conventional 140 had a decrease in major cardiovascular events, with the lower intensive treatment being better than the traditional systolic of less than 140. Next slide. You can keep going. Keep going. Here again are the blood pressures, and you can see the type of blood pressures that were achieved. Next slide. Huge population. Next slide. This is a new concept that I think all of us should be aware. Many times with older patients, we'll say they have Alzheimer's, and to a large extent, it becomes a wastebasket diagnosis. A lot of these patients actually have the ravages of poorly controlled hypertension and microvascular disease. And in fact, if you look at dementia, memory, and cognitive dysfunction, hypertension is a primary risk factor for small vessel ischemic disease with white matter abnormalities. Those of you who are clinicians, or if you have family members who are said to have Alzheimer's or dementia from aging, many times what it is the ravages of blood pressure. Better blood pressure control may actually reduce Alzheimer's disease and related dementias, and there's a strong association when you start lowering blood pressure appropriately that you can help cognitive function. Next slide. So hypertension is a primary risk factor for this small vessel ischemic disease. Next slide. It's predictive of cognitive decline and dementia. Next slide. Better control of blood pressure has a profound effect in preventing dementia. Next slide. And we have strong data to support that getting a goal of less than 130 is recommended for mild cognitive impairment and dementia. I think this is a powerful message for patients who not only want to affect the avoidance of heart attacks and strokes, but the loss of memory, loss of the ability to live independently. Next slide. Let me make a few comments on the 15-minute visits. Those of us who work in clinical care are often put in a box, 99214, where you're supposed to see patients, often complicated patients, in 15 minutes. And it's really hard to address the social determinants of health, since this has at least an 80% impact on patients' disease states. Next slide. I recommend, and this is from the guidelines, that we consider out-of-office blood pressure, where patients are given a valid cuff, or if their insurance can cover it, to confirm the diagnosis and titrate, often in combination with telehealth. In the 2017 guideline, it's a 1A evidence. Next slide. Out-of-office of blood pressure will remove the white coat hypertension effect, where about 20% of patients, and we used to think that they were wrong, but we now know they're right, 20% of patients will have elevated blood pressure with the anxiety of stress in the clinic environment. Next slide. Next slide. Next slide. Another approach that I think is beneficial is going into the community itself. In New Orleans, for several decades, we've had the Healthy Heart Community Prevention Project. It's a 501c3. We had an NIH grant many decades ago, and we continue to go into the churches and community centers to educate and empower patients about their cardiovascular risk factors. Next slide. And we now suggest that patients, if they can afford it or if their insurance can cover it, go to validatebp.org and get a blood pressure cuff which is validated and that the measurements we know are going to be true. Next slide. Next slide. We did a small pilot in New Orleans called Text My BP NOLA, and it was from Healthy Heart along with LA CATS, which is a consortium of all the various organizations, and Tulane University. Next slide. And what we did was give the patients a blood pressure cuff. This was a grant, small pilot. And in Text My BP Meds, we noticed an increase in medication adherence with text messaging and social support. Next slide. Starting at a blood pressure of about 142, we lowered it to about 131 plus or minus. P-value reached statistical significance. And these were real patients, 6 to 8% female, middle age and older, 90% Black. Next slide. And what it suggests to me is that empowering patients, educating patients will have a profound effect on blood pressure control. It's not enough just to go 2 to 3 times a year for the magic 15-minute visit. Next slide. The American Heart Association has a wonderful paper on implementation strategies for blood pressure control. This working group was chaired by Marwa Abdullah from Columbia. And what it suggests is that if you look at how to control blood pressure, next slide, going around the clock, there's several steps which may be key in controlling blood pressure. Let's start at 12 noon and move around the clock. Measure the blood pressure accurately. For the most powerful and conventional blood pressure risk, we don't do a good job in the clinic. Next slide. Use team-based care. The different colors, it's not just about the doctor. It includes nurse practitioners, physician associates, pharmacists, medical assistants, the patient and the patient's family. Next slide. The next cartoon, next slide, shows exercise equipment, but you really don't need exercise equipment. Physical activity helps with blood pressure control. Next slide. Standardized treatment protocol, helping clinicians to make sure that they're using the cocktail of medicines that's often needed and improving adherence with quality improvement. Keep clicking. Financial levels, keep clicking. And although President of the United States, we want to say that this doesn't exist, we know indeed it does. Some of the structural inequities, trying to dismantle those barriers to care that our patients often face. Next slide. I mentioned the 15-minute visit. The electronic health record is an important way to document care, but we as clinicians often spend more time treating the computer and the patient feels like a bystander. Next slide. So what I would suggest is that you know the evidence, we know the guidelines, we know the medications, we use lifestyle modification. What's most important, and this patient allows me to use this picture, is that we sit down, eye level, culturally competent, clinically appropriate language, talk to people. Next slide. Limit the amount of information. Don't overwhelm patients with our Latin-based language. Slow down. Avoid medical jargon. Use pictures and models and what we call the show me technique. After you finish, ask the patient any questions. What did I just say? Tell me what I just said. Because the patient who's empowered is going to be living with antihypertensive medications, living with the ravages of hypertension. And in order to avoid end-stage renal disease, heart failure, strokes, and even dementia, we need empowered patients. Next slide. Here are a few keys to controlling blood pressure. I'm not going to go in great detail, again, in the interest of time. Let's move along quickly. Have an agreement with the patient on your blood pressure target. Use combinations. Remember chlorothalidine and dopamine, long-acting angiotensin inhibitors, and calcium channel blockers. 90-day refills if you can. Telehealth is a powerful tool, connecting patients along with their care. Screen and address the social determinants of health. And number 10, the team. It's not about the doctor. It's a group of people, including the patients and the significant others, that are going to help to control blood pressure. Next slide. My final slide, the cartoon is from the CDC, and I have to check to make sure it's still up on the site. It shows the little lady with the boxes so that she can help reach the apples. People who are disadvantaged need help. The words are mine. Next slide. And what I suggest is that we need targeted interventions, next slide, to identify and eliminate disparities. These disparities are real, based on race, ethnicity, sex, gender, geography, socioeconomic status, ability, or disability. Healthcare equity, then, is not social science. It's a moral and practical impairment. Next slide. Thank you. Here are my contacts, and I try to stay on time so we have time for discussion.
Good afternoon, everybody. I guess while they're transitioning, I'll just go ahead and introduce myself and a little bit about my topic, I guess our gynecologic portion of the afternoon. So I am Dr. Christina Pardo. I am, currently obstetrician gynecologist at Weill Cornell Medicine and medical director for the women's health practice. I'm also proudly a part of the School of Public Health here at Downstate in the Department of Community Health Sciences. I think one more point of pride I'd like to say for myself, I think I'm connected to all the different elements that have put this together. So thank you for having me here today. I'm a proud graduate of the Downstate OB/GYN residency program and proud to have partnered with Health First on many initiatives. And last but not least, I am an alumnus of Howard University. That I always say the four most important years of my life. So thank you for bringing us all together here today. And so I'm going to talk about the global burden of disease for benign gynecologic conditions. Hopefully, I can share the importance of gynecologic conditions, not just obviously within our world of obstetrics and gynecology, but for all providers. And I don't have any disclosures relevant to this presentation. My objectives for today, to highlight the ways in which benign gynecologic conditions significantly contribute to the global burden of disease, define what are benign gynecologic conditions, review those inequities both at the global aspect and our local communities, and what are the social and medical burden of disease related to these conditions. So the global burden of disease is a comprehensive effort that was initiated to measure the health of populations across the globe. It studies mortality, morbidity, and risk factors, as well as health systems. The key measures that are used for to evaluate global burden of disease are one called the DALYs, Disability Adjusted Life Years, which quantifies the total years of life lost due to death and disability. Second, years of life loss, which measures the years of life lost due to premature mortality. And years lived with disability, measure the years of life lived with disability or health conditions. I don't know if I move this mouse so you can see it on the screen. Do we have a pointer? No? And so the graphs, the maps that you see on the right side, or I guess the left side, shows you the number of data sources in the... This one? Okay, I will do that. Let's see, maybe I can move this way. Great. What you see here in these maps are the number of data sources from each country. So obviously, unsurprisingly, countries that are considered quote unquote high income will have higher number of data sources versus the historically impoverished countries. And so when we look at the global ranking of the DALYs across for women specifically, we see that women have higher burden of morbidity-driven conditions. So this is a graphic that shows the morbidity for females versus male. And while you see, ischemic heart disease, and stroke at the top, you see more of a prevalence of the morbidity related conditions for women, most notably low back pain, depressive disorders, and headache. As we moved really towards looking at women's health and gynecology, I really want to paint the picture or hopefully the message that we'll send in looking at women's health and gynecologic conditions from a life course approach to women's health. Oftentimes, women's health is viewed around various reproductive health, specific time periods within a woman's life, but really looking at a life course that incorporates the different aspects of life, how that contributes to not just gynecologic health, but also the reverse, how the gynecologic health also impacts the chronic health disease risk. So as global burden of disease for gynecologic conditions, among non-communicable diseases in women of reproductive age, gynecologic conditions are ranked second worldwide for the disability-adjusted life years. So within the field of global health, we know that over the past couple of decades, there's been a trend moving away from where infectious diseases were at the top and now moving more towards non-communicable diseases as there's been more advancements in the management and access to HIV/AIDS and other infectious disease conditions. And unfortunately, the progress in reducing that burden related to gynecologic diseases has not met the target that was set for those. And some of the things, we'll go into more detail, but at the high level, some of the things that contribute to that is just the nature of gynecologic conditions as well. So there tends to be more of an insidious onset. There is a higher prevalence and oftentimes maybe just an acceptance of conditions, can have easy recurrence and often do span the entire life cycle for women. As we look at comparing the global burden disease from benign gynecologic conditions based on stratification of the type of country. So at the global level, it's usually divided between, high income or more resourced countries versus impoverished countries or have considered to be lower or middle income countries. So we see that for the more resource countries, at least the burden of disease for gynecologic conditions is less, 3.95%, versus lower impoverished countries, which is at 5%. And what's important, so the impoverished, I don't like to say low income, the impoverished countries do have a higher burden, but what's important about this, it's not about, where they have a higher rate of certain conditions. It's the burden related to the reduced access to care and services related to those conditions. So we'll take our time to just define gynecologic conditions. Again, just to create a neutral space for everybody. I know not everybody is lucky enough to be a gynecologist, so we'll kind of level the playing field. So benign gynecologic conditions are non-cancerous conditions of the gynecologic system. So we have obviously the ovary, the fallopian tube, the uterus, the cervix, and the vagina, not pictured here as external, where you have the vulva. And the benign gynecologic conditions include fibroids, PCOS, infertility, genital prolapse, endometriosis, miscarriage and abortion, ectopic pregnancy, pelvic inflammatory disease, and other, which is a large kind of catch-all. That includes menstrual and non-menstrual conditions. So the menstrual conditions, including abnormal uterine bleeding, all the way to the menopause and perimenopause conditions, and the non-menstrual conditions, including vaginitis, breast conditions, non-inflammatory conditions of the gynecologic tract, endometrial hyperplasia, and non-inflammatory disorders of the cervical and vaginal disorders. And again, just to give, this is like everything within obstetrics and gynecology. So everything that we do within gynecology, the symptoms that relate to gynecologic conditions and also how we treat really go between this graph and the next one that I'm going to show. This is our menstrual cycle. So this is the physiologic aspect of it and the way, the ovary develops within a menstrual cycle and ovulation, and then what happens when you don't have a pregnancy following that time point. The hormones, the changes in our hormones within the menstrual cycle. So from a physiologic perspective, a lot of this, both the symptoms and the interventions are related to controlling this right here within the physiologic aspects of gynecologic conditions, and not just that, towards infertility and also preventing pregnancy. And so when we talk about the physical, the anatomic contributions to causes of gynecologic conditions, that's where we see everything on this graphic here, where we see the uterus, and where you can have malignancy, fibroids, myoma, adenomyosis, which is when the lining of the uterus, the endometrium, can migrate into the wall of the uterus. Uterine polyp, which is a growth within the lining of the uterus. Coagulopathy, which is related to, obviously that can contribute to heavy menstrual bleeding. The ovulatory dysfunction, which again goes to our previous graph, the physiologic components of the gynecologic system. Iatrogenic, so if you have a foreign body like an IUD, that contributes to gynecologic condition. So as over the past years, there's been more of a focus of evaluating what that actually translates to, or documenting the global burden of gynecologic conditions. And so these graphs kind of show this particular effort in really detailing the impact of gynecologic conditions. And what they found is that other gynecologic conditions contribute to most of the burden for gynecologic conditions, and that is in both high-resource countries and impoverished countries. What you see within the impoverished countries, you have the increased percentage or the burden of that large catchment of other gynecologic conditions. Also, following that, you will see endometriosis, uterine fibroids, PCOS, which I'll go into a little bit further detail. When you now look at it based on the age group, unsurprisingly, we see the highest burden is going to be around that reproductive age group, and starts to decrease from that point, even for higher resource countries, for 70 plus. They didn't even have a figure for that. Again, without anything that directly says correlates to this, but it may be related to the access to resources and treatments in more resourced setting. Surprisingly, also, the benign gynecologic conditions as it relates to now morbidity, in total, has higher burden for women compared to HIV, malaria, and TB combined for the reproductive age group. So we see here, for example, in impoverished countries, we see the pink being the benign gynecologic conditions, and HIV/AIDS here in the maroon. So as a combined, all of the gynecologic conditions have a higher burden of disability than the HIV/AIDS, malaria, and tuberculosis. And we see that across the spectrum here. And this is just detailing that, comparing the across the age groups. So if the traditional reproductive age, 15 to 49, and going up from that point. And unsurprisingly, once you get to age 70 and up, you see that, the burden related to benign gynecologic conditions decrease as do with the other conditions. This is just another way to demonstrate it. This particular study evaluated not just the benign gynecologic conditions, but they also included some of the gynecologic malignancies when looking at DALYs specifically. And so, they for each of the different regions, they kind of ranked the contribution towards the disability for that particular region. And so HIV/AIDS, unsurprisingly, is number one for many of them, but not all. And so you see, it kind of goes between HIV/AIDS and other gynecologic conditions. However, many of the other underneath that
are gynecologic-related conditions that's contributing to the morbidity. And this is just showing the global burden from gynecologic conditions from a global aspect, the contribution to morbidity. Another way that they were demonstrating this, again, showing the different conditions, including the gynecologic malignancies, HIV/AIDS, sexually transmitted infections, and they added into this graphic really detailing the differences based on the age. So in this particular, which was on the top row, which is focusing on DALYs, we see that as we are moving from HIV/AIDS to more the malignancy and conditions that usually start to have a presence beyond the reproductive age, we start to see the increase in uterine fibroids, genital prolapse, and the malignancies. So to bring it to the United States, there has been, thankfully, as we all know, increased focus on health disparities, including within obstetrics and gynecology. So this is a really great committee statement that was published by the American College of Obstetrics and Gynecology on racial and ethnic inequities within obstetrics and gynecology. We most often obviously hear about maternal mortality, which is unacceptable and important. But what was also often lost with that is the disparities within gynecologic conditions. So we've come a long way from, initially it was always infant mortality, and then we started talking about mom and maternal mortality, and now we're kind of looking at as the woman in total. So, unsurprisingly, we see the disparities among many conditions within obstetrics and gynecology. I'm going to take a deep dive on some of the conditions just so we can understand conceptually what the impact of a global burden of disease, not just on an individual, but on an actual system. So when it relates to fibroid uterus, which affects about 70% of women who identify as Caucasian and 80% of women of African ancestry, it is considered the most common benign tumor of the female reproductive system. And now when we look at the burden within a system, in the reproductive age, about 30% of hospitalizations, they account for 30% of hospitalizations related to gynecologic disease and are the reason for about 40 to 60% of hysterectomies. And at the health system level, this contributes to annual income loss caused by uterine fibroids in the United States was higher than the total treatment costs for a breast, a colon, or ovarian cancer. And if we look at it from a global picture, the burden for uterine fibroids varies widely around the world, and a lot of that contributes to socioeconomic status and population structure. In 2019, higher resource countries had the highest age standardized incidence rates. And again, that's not because the actual prevalence is higher, but it's also related to what is accessible in the community, having adequate medical resources and health systems to actually be able to diagnose those conditions. So even though there's a higher documented prevalence, still the impoverished nations had the higher rates of disability related to fibroid uterus. So to move to PCOS, polycystic ovarian syndrome, which is a complex syndrome that includes metabolic, reproductive issues related to hormonal imbalance. This condition is probably the most connected to a lot of our chronic medical conditions like hypertension. In the presentation just before mine, the symptoms are irregular periods, androgen excess, and is the leading cause of infertility. And when we look at the economic burden of PCOS, just in the United States, it is estimated to exceed 15 billion. Direct costs related to diagnosis and treatment, indirect long-term health complications, mental health disorders and reduce productivity. And there has been noted correlation with mental health conditions with PCOS. And I will say, as a gynecologist, this is really one of the most challenging conditions to manage or to support your patients, because often there isn't, a clear, there isn't a cure per se or treatment that works, across the board. So it really requires a lot of counseling and support and helping the patient to navigate their diagnosis, which is very similar also with endometriosis, which affects about 10% of reproductive age women and girls. It is a chronic disease associated with severe life-impacting pain, painful intercourse, bowel and bladder issues, and chronic pelvic pain. There is no cure, similar to the PCOS, and treatment is really aimed to controlling the symptoms. And again, this symptom burden that many women are experiencing leads to a total economic burden of 78 to 119 billion billion annually. As we now try to look into what does that mean for our communities from a disparities standpoint, and especially our communities here where we have a large population of foreign-born individuals, as when studies that are done nationally, especially for conditions like this, we know that for those who are identified Black or African American are usually a combination of several different subsets within that, so it makes it harder to understand the way conditions may present or the best way or the symptomatology or the best way to treat within different populations. So it makes it difficult, limited data for subgroups within the overall Black population. So as I try to really get a little deeper dive than what I just showed, especially for our Black and immigrant population, there are a few studies that evaluate gynecologic disparities specifically among Afro-Caribbean populations, and much of those are really within the malignancies, endometrial, breast, and cervical cancer. But when they did, unsurprisingly, there were disparities that were seen. So this particular study that was done in Miami, which, similar kind of population to what we have here, found that compared to U.S.-born Black women, Jamaican and Haitian-born Black women were more likely to have higher grade histology, present with more advanced disease, and receive chemotherapy. And also that Haitian-born women in particular had worse overall survival outcomes. And we all know that's not related to biology. A lot of that often is the access, and also for the cultural aspects and the comfort with receiving care in different settings. And of course, the issues surrounding being having immigrant status and barriers that may play. And I couldn't do a presentation without talking about maternal health disparities just a little bit, based on the work that I do here in Brooklyn. And so these disparities, obviously, we see within maternal health. And the New York City Department of Health, as we saw, Dr. Easterling has done a lot of great job. And what they did is they really disaggregated the data. So we were really able to see disparities, not just for a total population or a total racial group, but subgroups. And so one thing that was quite notable as it relates to severe maternal morbidity is that Black foreign-born women have had the highest risk of pregnancy complications. They didn't have the highest numbers, but they did have the highest risk of pregnancy complications, with those born in Haiti being at the top. And if you haven't read this publication that just came out from the Department of Health just a couple months ago, I really encourage you to read it. I added the QR code, so if you want to look it up, where they really did a phenomenal publication on the health of immigrants in New York City. And again, we see the disparities there within our perinatal health populations, with, unfortunately, Jamaica and Haiti and Guyana being at the bottom of the list as in those receiving timely care. And with infant mortality, we see the reverse, Haiti, Jamaica, and Guyana having the highest risk of infant mortality here in New York City. So, back to our gynecologic care and summarizing the disparities in access to both obstetrics and gynecologic care. We know that racial and socioeconomic inequities influence access to diagnosis, treatment options, and health outcomes here within our communities nationally and globally. But now when we get to the patient-specific aspect of it, it has been documented that women are less likely to participate in shared decision-making, reduced access to care, information, and services for both obstetric and gynecologic conditions and procedures. For within the obstetrics side of things, we hear that a lot around cesarean deliveries, and then obviously for this aspect and some feeling, being pushed to have one particular decision to manage their gynecologic condition. And then nationally and globally, disparities in access to gynecologic care and minimally invasive surgical options. So this is what really drives the morbidity aspect. So now you have fibroid uterus or whichever condition that's really contributing your daily life, and you don't have access to the surgical management to it. And perhaps even if you have access to surgical management, but not to minimally invasive, that can have the reduced impact on your overall life. And all of these things contribute to the delayed diagnosis and treatment, higher rates from the mortality rates from gynecologic cancers, underrepresentation in fertility treatments, and socioeconomic barriers to preventative care. So hopefully at the time where some of these conditions can be managed medically. And here in New York and across the United States, obviously that access to primary care facilities really is diminished, especially depending on where you live within the city and where you live across the United States. And when we add the immigrant and cultural aspect to it, we see that, of course, we know that race plays a role in our access to care and also the way we're received when we are attempting to receive care. And then we add the immigrant or foreign-born aspect to it. So the difficulty in navigating system, perhaps there's a language barrier, fear, especially we're, unfortunately are experiencing more of that now, and also a distrust of the care. And so this intersectionality and levels of barriers of care are most prominent, especially in communities here in central Brooklyn. And this translates to the social and medical burden. Now when we talk about women and gynecologic conditions, unfortunately, some of it related to the nature of the condition, having a chronic component to it that impacts the functional impairment, the ability to live, to care for your children, to be able to work, delays in diagnosis and treatment, economic costs, not just for you as an individual, but for an entire system, the mental health impact, and stigma. So unfortunately, there has always been a stigma around reproductive conditions and gynecologic conditions, which can make it harder for women to seek care. So, in my, final message, I really hope that in pursuing a life course aspect to women's health, we can begin to reduce the stigma so people are more comfortable to address their gynecologic conditions early, while also we're working to improve the access to care. This is a big driver for gender inequality. Again, chronic pain, stigma related to accessing care related to these conditions. There has been an increase in advocacy. You see this especially around menstrual inequity. You see the sign here, and the period poverty. So this is not just globally. Even here in New York City, there's a big focus on menstrual equity, for example, in homeless shelters and different settings, and really pushing for holistic and life course care for women. And I can't end without, one of our great pioneers within our community, leaving us with some inspiration. And thank you for having me.
Good afternoon, everybody. I'm glad that we have everybody still here. I'm going to try to make up for a little bit of, I see that I have 15 minutes to give my talk. It's a little bit longer than that, but I'll try to make up for some time. I thank Dr. Pardo for sort of setting the stage for a little bit about what I'm going to talk about, which is specifically a gynecologic condition, which is one of the most commonly found gynecologic conditions globally, locally, everywhere, which is uterine fibroids. This is going to be an overview of disease and disparities. And just a little bit about myself. I'm by training a urogynecologist and fistula surgeon, so the bulk of my work through my organization, IMR, is abroad teaching surgeons skills to repair maternal birth damage in the form of obstetric fistula, as well as prolapse and incontinence. But everywhere I've gone in the 5 or 6 different projects we have around the world, one thing I always see, since I care for women exclusively, is uterine fibroids or myomas. So I thought it would be nice to really spend a little bit of time with you guys and talk about that. These are my purpose and objectives. You can read those for yourself, but initially just going over the epidemiology of fibroids, clinical considerations, and ending up with disparities in fibroid care, again, expanding a little bit more on what Dr. Pardo had gone over. The overview of fibroids are also known as myomas and leiomyomata. So all 3 words refer to the same condition. We'll talk a little bit about prevalence, symptoms, diagnosis, and treatment options. What are myomas and how prevalent are they? So the actual definition is that this is a solid neoplasm. So it's a benign tumor that is composed of smooth muscle cells and fibroblasts. They vary in size and the places that they occur in the uterus, and it is the most common benign pelvic tumor in women. Here's a schematic of just where you can find them. Anywhere that you have uterine fibroid tissue or uterine tissue can form a myoma. So they can be submucosal, which is under the endometrial lining. They can be hanging off, pedunculated. Let's see if I can get this. Was there a pointer? Or oh, roller ball. Oh, okay. Yeah, so pedunculated, like a little earring hanging off your earlobe. They can be really inside the uterine cavity. They can grow just under the serosal layer. They can also be found throughout the perimetrium after surgery. They can seed after being taken out. And so they're very interesting places where they have been, in case reports, found. And depending on where they are and how big they get, that really does lead to the kind of symptoms that women have. So FIGO, which is our International Federation of Gynecology and Obstetrics, it's our international organization, has a very elaborate sort of classification system. But again, you can see depending on where they grow, where you have smooth muscle that can become a fibroid, can definitely impact the kind of symptoms that people can have. They are very, very common, and we think up to 70% of women globally will have fibroids, but only 25% are symptomatic, so we actually don't really know how many women have fibroids because many can be asymptomatic. Again, largely unknown incidence, but it increases with age, family history, hypertension, diabetes, and some chronic conditions. It's 2 to 3 times higher in Black women, and it occurs in almost 70% of Caucasian women and in greater than 80% of African American women by the age of 50. Black women have earlier onset, more anemia, larger fibroids at the time of diagnosis, And it's been speculated and shown in several studies this is likely to systemic racism and social determinants of health, again speaking to delays in care, lack of access, and racism in our medical delivery system. We have higher rates of hysterectomy and open surgery in African American women who have uterine fibroids, even when it's controlled for the uterine size. And symptoms, there's a wide range of symptoms. You can have bleeding that can be prolonged and heavy with clots, ultimately leading to anemia, in some cases requiring a blood transfusion. There can be a lot of pressure symptoms associated with uterine fibroids. They can get as big as a full-term pregnancy, or stay, again, small, but depending if they press on the bladder, you can have urinary symptoms, you can have a lot of pelvic pressure symptoms, symptoms that affect bowel movements if they're towards the back against the colon and large intestines. And so it can really show up in many different ways. As far as diagnosis, we always start off with the history and examination. So we ask about symptoms, growth. If you've noticed a growth or pressure, people can actually palpate and feel fibroids when they get big enough to pull it up out of the pelvis. Pain, bleeding symptoms are really important. Like I said, you can have abnormal bleeding that can lead to anemia. So testing for anemia and blood counts is part of the workup. And again, imaging. After your physical exam, transvaginal ultrasounds, sonohysterography, hysteroscopy are all different ways that we can diagnose not only uterine myomas, but also find out where they are specifically. And with MRIs, they come into play when we're talking about surgically planning removal of the fibroids. We want to make sure that we also evaluate for other pathologies that could get masked because many times women are dismissed. They say, oh, you just have fibroids, so there must be nothing else really going on explaining your bleeding or your pressure symptoms or your pain. So we have to always be very aware and vigilant in ensuring that it really is these smooth muscle tumors that are causing the condition. And one other thing I just want to bring up is the malignant sarcoma, because at times myomas can be just treated as benign and no high index of suspicion that there could be one that has undergone transition to a malignancy. So here's just an MRI that you can see here of large myomas, and these are all the ball-like structures are the fibroids. And you can see they can get quite large. They can get big enough that they push on the diaphragm, and you can have respiratory symptoms as well. And you can see where they occur and how big they get can really lead to a lot of discomfort and symptoms that women do feel. Here's a pathology specimen postoperatively of a cut section of what these fibroids can look like. And oftentimes, it's not common that you just see an isolated, 8-centimeter myoma that's just sitting at the top of the uterus. Oftentimes, you'll have multiple fibroids. As you can see in this picture here, there's one that's into the cavity, distorting the uterine cavity. There are smaller ones on the outside. And as you know, or if you don't know, gynecologists are definitely obsessed with fruit. So we always talk about ovaries being a certain size, it could be an almond, but we also talk that way about fibroids as well. So we categorize them as small, medium, and large. And yes, again, using fruit as our reference point. A little bit about the leiomyosarcomas. They are a rare malignancy, but can be very deadly if they're just confused and sort of confused as normal myomas that are benign. So this is a leiomyosarcoma that is coming out of the myometrium into the cavity, and it's been opened, and you can see it has an irregular nature, and it's really on the final pathology that it'll be diagnosed as an actual cancer. As far as sarcomas, I'm going to bring it up again because oftentimes they can mimic benign fibroids and are often dismissed as such. They are uncommon, 8% of uterine cancers, but intraoperatively, if a case is being done and being treated as benign, they can spread pretty rapidly. And that's what we've seen a lot more, especially with minimally invasive cases where a patient was told they just had fibroids, but it turned out to be on final pathology that there actually was a cancer cancerous leiomyosarcoma, but by that point, because the surgery had been done, the cancer had already spread intraperitoneally, and once that happens, it's very hard to treat. They can be rapidly growing, so one of the questions we ask also with somebody who presents with uterine myoma or fibroids is, how fast have you noticed the growth? Has it been all of a sudden something has started to grow and you can palpate it? But again, one of the things is it can be really hard to distinguish on the imaging you get. So I think a high index of suspicion is always good as clinicians. So again, this is a leiomyoma or regular fibroid on the left, and then one that is a leiomyosarcoma towards me, which you can see increased mitosis and cellular disarray. And as far as treatment options for fibroids, many times, since many women are asymptomatic, and it could be an incidental finding on an ultrasound for another reason, if patients are asymptomatic, you can do expectant management, which means that we don't offer any treatment, but just keep an eye on it. There's medical management options, complementary and alternative medicine options. There's really a lack of evidence so far for fibroids. And then interventions, which we should always have as patient-centered, shared decision-making, but they're symptom-focused. And again, we have to be aware of a patient's desired fertility because we're talking about the uterus, and a hysterectomy is not always going to be the best option for a patient, nor acceptable. And then surgical options. So expectant management, candidates are women who are asymptomatic. Again, patients who are approaching menopause are also ones who can be candidates because myomas, since they are dependent on hormones like estrogen and progesterone, as you get towards menopause, many of the myomas will decline in size, and symptomatology will also then regress. And how to follow is, on annual exams, just a quick examination, making sure you evaluate your patient for a change in symptoms, and that's adequate. As far as medical options, we want to focus on the symptomatology. Is it pain? Is it excess bleeding? For bleeding treatments, we have medications that we can offer, and GnRH antagonists can be effective for blood loss. Up to 88% of patients will have improvement, but you can only use it for up to 24 months. IUD with hormones can also decrease the amount of bleeding if that's a primary symptom. Combined oral contraceptive pills can be an option. Tranexamic acid can also limit blood loss. And depending on the bleeding and the size, GnRH agonists can also be used. But usually those are used getting ready for surgery to help a patient build up their anemia if they have anemia. And the one that we use for that is injection Lupron. Again, it's bridging until another strategy or intervention. It can decrease blood flow, decrease myoma size, but once you stop the treatment, the actual fibroids can grow back 3 to 9 months after you've stopped the treatment. As far as interventions, we have a fairly large variety. We have uterine artery embolization, radiofrequency, focused ultrasound, and endometrial ablation. I'm just going to quickly go through each one of those. As far as uterine artery embolization, it's recommended as an intervention for uterine preservation. You have embolic agents that are delivered through catheterization in the uterine arteries, but it can cause devascularization and involution of the fibroids, and you can have significant reduction in size for up to 5 years. It does improve bleeding symptoms, but again, there is a high rate of reintervention that may be needed, fibroids that can grow back. And here's just a schematic of what that looks like. You have catheterization through the femoral artery, and then pellets are delivered, obstructing the uterine arteries, which will feed your growing fibroids. There are complications, 1 to 12% of major complications, including unplanned hysterectomies, rehospitalizations, ovarian failure, because again, the uterine arteries, if you're blocking blood supply to them partially, it also can affect ovarian function. You can have minor complications. There is limited data on fertility in the future, but we do know you have increased risk of pregnancy losses, C-sections, and postpartum hemorrhage in women who've undergone uterine artery embolization but then gone on to have a pregnancy. Radiofrequency ablation was first reported over 20 years ago. It's safe to use, also uterine preserving. It's not commonly used, though. As far as focused ultrasounds, it's using high-intensity ultrasound to cause necrosis. Obviously can be painful, but it's not recommended at this point after small trials were done. Less improvements in symptom of quality of life, and over 50% of women needed some sort of other intervention to help treat their symptoms. There's endometrial ablation that's used for various different things. It's an intervention that actually destroys the endometrial lining, so this would be good for patients who may have bleeding disorders, but there is insufficient evidence to recommend it for treatment of uterine myoma-related bleeding disorders. But what it is essentially a balloon that's kind of put in with heat, and what it does is it destroys the endometrial layer. And we have surgery. Lastly, we have surgery. As a surgeon, I always talk about the surgery, but considerations, again, you're dealing with women at different phases in their life, different life cycles, and fertility considerations are a definite something that we have to consider. Fibroids can cause cavity distortion, as I showed you, the ones that come into the cavity. So surgery that can, if you're thinking about future pregnancies and worried about the endometrium being distorted, removal of those fibroids would be an option. Again, anemia is found very commonly, so preoperative management, if you're considering a myomectomy, which is where we just remove the fibroids, leaving the uterus intact, or hysterectomy, where the entire uterus is removed, and this is definitive therapy. As far as myomectomies, that's where, again, the fibroids are removed. It's a consideration if a woman wants to keep her uterus for whatever reason that may be. It could be fertility, it could be cultural. It's a very personal decision. Myomectomy can be performed hysteroscopically, which is taking a small camera through the cervix into the uterus and removing the fibroids. Laparoscopically, which is minimally invasive. Robotically, also minimally invasive. Or abdominally, where you have an open laparotomy. All of these studies have shown that myomectomies do improve quality of life. It's not 100% clear if it takes care of almost all bleeding issues, and pregnancy rates do differ if it's subserosal versus submucosal. Again, fibroids on the outside don't necessarily distort the cavity as much, so you can imagine those that are submucosal or in the actual uterine cavity, pregnancy rates may be lower. A hysteroscopic myomectomy that I had mentioned is actually where a resectoscope is taken through the cervix, and a submucous fibroid is sitting there distorting the cavity, and it's essentially like a hot knife through butter. It's using cautery to remove fragments of the fibroid that are distorting the cavity. So at times you can't always get the entire fibroid out, and you certainly don't have access to ones that aren't immediately available there in the cavity. It's low risk of complications, though, and low reintervention rates. For the right patient, it's a good option. As far as laparoscopic or robotic myomectomies, it's great for symptomatic treatment and, again, uterine preservation. It's faster recovery time and less post-op pain has been noted. The short-term quality of life is the same as an abdominal myomectomy, which is an open laparotomy myomectomy. But we have studies that show that there's increased rates of recurrence of fibroids if there's greater than 5 that are removed. As far as using the robot, everybody likes to bring up the robot when they talk about surgery. It offers no benefit as far as OR time, blood loss, or hospital stay, but then the surgeons do get to say that they use a robot. That might be the main benefit. As far as hysterectomy, which is actually removal of the entire uterus with the fibroids in situ, it's recommended as definitive solution. Myomas are the leading reason for hysterectomies in this country. Again, if a patient doesn't have any future fertility desires, it may be an option. It can obviously will improve the anemia because you're removing the source of the anemia. There's improved quality of life, and if possible, The vaginal route is preferred just because it's minimally invasive and it has lower complication rates. It's better for the patient. And as a primarily vaginal surgeon, I always try to make a push for it if it is possible, because sometimes the uterus may be so big with the myomas, it may be physically incredibly challenging. Again, ultimately, we want to focus on quality of life. The effects of doing myomectomy and hysterectomies do offer improvement in quality of life symptoms, both in long-term and short-term studies. And a little bit on, just going to finish up with health disparities in fibroid and myoma care. Healthy People 2030 from the Department of Health and Human Services defines health disparities as a particular type of health difference that's closely linked with economic, social, or environmental disadvantages, which are the result of the social, structural, and political context. There was a systemic review done a few years ago by Keaton et al., which showed that the prevalence of fibroids are higher in Black women. It's possibly due to an increase in exposures that cause the fibroids. It could be a lack of access to high-quality care, allowing for them to get bigger. And also that there is a higher rate of negative experiences that women Black women that enter the healthcare field for care do experience. Are there biological differences in fibroids? And we do have evidence from 2024, Bateman et al. Did an analysis of microscopic histologic analysis and found that fibroids in Black women compared to white women had a higher incidence of mutations, had increased extracellular matrix proteins, and stiffer phenotypes, that the fibroids themselves were actually firmer. And in the same year, Bariani et al. Found that there was a higher extracellular matrix proteins in the myometrium, or the actual muscle of fibroids in Black women, before the fibroids actually developed, thereby possibly leading to the conversion of normal myometrial tissue to fibroid tissue. So there is evidence to show that there is a difference histologically in Black women and white women's fibroids, which needs to really come into play, because that means that we need to really have a different understanding of how we treat, diagnose, and care for women based on their ethnicity and race. As far as gene expression, we know that the genes expressed by fibroids are impacted by allostatic load. Allostatic load are chronic daily stressors. Racism, sexism, and other marginalizing harmful factors can actually impact the rate of gene expression. We know that hair products, relaxers, straighteners with chemicals are associated with an increased risk of fibroids, and Wise et al. Found that ever versus never use of hair relaxers among Black women was associated with a 17% higher incidence of uterine fibroids. And there is clearly disparities in treatment, and we have a lot of evidence to show this. We know that Black women are more likely to undergo surgical intervention as opposed to other more non-invasive options. There are higher rates of hospitalizations, myomectomies, and hysterectomies when you compare it with white women. The post-operative complications are significantly higher in Black patients compared to white patients, with an odds ratio of 2.5, and this could be because of the rate of interventions and the type of interventions, that they're not necessarily offered the most minimally invasive intervention, which has lower rates of complications, and that's something we know. We know that pre-op blood transfusion rates are also higher. And religious restrictions on transfusion. There was one paper that said may have found a role just because more Black patients may be Jehovah's Witnesses, and there's a restriction on transfusions. Also, this could impact and delay the avoidance of medical care, making the fibroids possibly get worse, get bigger. So that could have an impact on transfusion rates as well. And then there was another study in 2010 that reported that a lot of the bigger studies with fibroids actually didn't even report race or ethnicity. As far as the socioeconomic impact and fibroid care, we know white women and women of other racial groups with private insurance are more likely to undergo laparoscopic or minimally invasive procedures, such as the robotic procedure, the laparoscopic procedures. And that African Americans, Hispanics, and women with Medicare coverage are more likely to undergo abdominal procedures, even for the exact same indications when they were put side to side. So If you undergo an abdominal procedure, that's a much more invasive procedure. Hospitalizations are longer. Risk of postoperative complications are higher, including infections, bleeding, and other things that can come after abdominal surgery. As far as the socioeconomic impact and fibroid care, a meta-analysis just earlier this year from Hassemi et al. Reported that non-white patients often demonstrated lower access to minimally invasive surgery utilization and higher rates of surgical morbidity than white patients, and that Black and Hispanic patients were less likely to undergo, again, minimally invasive operations compared to white patients. And again, so this impacts the complication rates, it impacts postoperative complications, intraoperative complications, and non-white patients from the same study had a higher risk of, again, developing surgical complications after hysterectomy, whether or not they underwent a minimally invasive procedure or open hysterectomy. So those are all very interesting findings, again, earlier from January this year. It's well documented that Black women have a 2 to 4 times higher incidence of high-risk cancer types and worse outcomes due to many factors, including high-risk subtypes. So just a little bit about uterine cancer care. I want to just go back to the leiomyosarcoma that I brought up earlier. Factors include access to care, symptoms, and bias in diagnosis. And the incidence of non-endometrial subtypes was higher in Black women compared to white women, with the most pronounced differences seen in serous carcinoma, carcinosarcomas, and leiomyosarcomas, all with pretty less than favorable outcomes. And again, this was in September 2024 from one of our bigger journals, the American Journal of Obstetric Gynecology, which clearly pointed out that the fibroid crisis in Black women, more work needs to be done. Work needs to be done, on an intervention outreach level, on the care that we give, on options that are given to women, and also research, knowing now what we know as far as biological differences. As far as recommendations to consider, again, there are many treatment options. There's expectant management, but also surgical versus medical, depending on what your patient may desire. And the best outcomes occur, again, with patient-centered care, shared decision-making, and culturally competent care, which I think is remarkably important. We know that disparities in care impact on fibroid pathology and diagnosis and care are prevalent, and everything from the microscopic level of gene expression to structural causes that do impact fibroid care. And that's it. Thank you. Do you want us to stay up here?
All right, everyone. Thank you. That was excellent, informative. I learned a lot. We have a few minutes for questions. Are there any questions for the panel? Dr. Ferdinand is back? Okay, good. I'll start. Dr. Ferdinand, could you speak a little bit about the practice that you have of the reminder text regarding blood pressure?
Text my BP NOLA. It was a sponsored small trial. In general, what's being recommended now is that we try to get valid devices for our patients. That's what the validatebp.org website is.
Okay.
Because patients often have blood pressure in the clinic, in the home setting, it could be normal. Or in some rare cases, it could be normal in the clinic and outside the clinic be elevated. So out-of-office blood pressure, not only from the 2017 guideline, but the United States Preventative Task Force, it's a class 1 approach. And it makes sense because if the patients measure their blood pressures and you're able to communicate either by texting or by telehealth, it's better than just waiting for 2 or 3 times a year for a condition that's omnipresent. I mean, people live with their blood pressure 24/7.
Yeah, okay, I like that idea. Any Anybody else with questions? 'Cause
We
if
have a
not-
question online.
Okay.
This one's also for Dr. Ferdinand. Is there any health significance or difference in response to therapy related to the ethnicities of study samples in China compared to in the US and other places?
Well, in general, there's a movement away from saying which drug for which person based on race, ethnicity. And indeed, the Chinese studies may be criticized because it's not a heterogeneous population as we have here in the United States or in Brooklyn. But at the same time, it's pretty convincing that lower is better, that the 140/90 is not good regardless of race, ethnicity, that we should target lower blood pressures. Now, the idea that, for instance, Black patients use a diuretic or calcium channel blocker versus an ACE inhibitor or an angiotensin receptor blocker, we really think that the main thing is to recognize these patients are going to need 2 or more medicines. So now the push is not for which medicine based on race, ethnicity, but a combination of medicines for all patients. There is a study from West Africa called CREO, in which they used a combination of an ACE inhibitor and calcium blocker in the West African population. They did excellent in terms of blood pressure control. So I think the take-home message is medicines aren't bad. I think the United States population is making a big mistake with this move away from science and medicine. Lifestyle modifications, of course, needed. Too much salt, not enough potassium, too much obesity, physical inactivity. But that it will be a combination of medicines, often 2 medicines in 1 pill to control blood pressure in these difficult to treat populations.
Thank you. Another question?
Hi, I'm Dr. Pardo. Yeah, just curious, just out of curiosity. Are you hearing me clearly now? Yeah. Just out of curiosity, I was wondering if the increased gynecological risks that seem to be evident on a global level, whether that affects women employability in the workplace, and does that have any implications for their economic well-being and that of their families?
Thank you. That's really a great question. So a lot of the, when they look at the global burden of disease and the impact of disability, from the economic standpoint, that's where a lot of that burden comes from, and the economic impact, on a society. So, lost days, at work, not just at work, in school age, related to menstrual hygiene. So, lost girls missing days from school, and depending on the country and the structure, says what type of support is there or protections for women. So that's not just gynecologic, it even goes to pregnancy, and it relates and parental leave as well. So, unfortunately, sometimes employers may say, there's a higher chance that this individual is going to take a maternity leave, and then what the impact is on their business. So from the gynecologic perspective, the financial and economic burden is not just the direct costs, but the costs related to employment. So missed days, the functionality, being able to function at work, and also even at the school age, the missing school. And there have been, at least at the school level, school-based interventions to address menstrual inequities at the school level, where when they had interventions to increase access to menstrual products and reduce the stigma, that school attendance increased, at least in those particular countries.
Okay. Another question? Am I loud enough? I can hear you, but I'm not sure if everybody in the back can. Can you? Okay, thank you.
Hi, I wondered for both doctors, is there an increase in family sharing history? All right, because my experience is that sometimes you find this running in families, the fibroids, all of the different things that you've described. Are families increasing their discussion from generation to generation?
Good question.
And most of the work that I do is in uterine prolapse, and they're also a huge component of. Oh, sorry. Well, I guess you could hear me anyhow. No, but I think that's a really great place where if there was somebody who had some initiative to make that, you know, more widespread, that would be fantastic.
I certainly think it's a place to start for women, and with all of the things we've talked about today, this whole issue of families discussing things that appear to run in families.
Yeah. And I think that's really interesting with gynecologic care and the, you know, matriarchal lineages and the way that we talk to our, you know, daughters and mothers and grandmothers, because a lot of these things do run in families, but a lot of times they're also kept secret. And it's not passed down because of, well, at least in the world of prolapse, shame. In the world of incontinence, there's a shame associated with it, and people are shy to talk about it. But I think that, you know, we need to get over that so we can pass on the wisdom and pass on what we know.
This is such an important topic and question. I think it goes to that stigma. You know, it's never talked about, and I think it's just kind of in women you just deal with. It's a part of life. You struggle through it, you suffer through it, and therefore you don't talk about it, and so you feel your experiences are your own. I remember when I was doing residency, I mean, I was so surprised, you know, like my grandmother had a hysterectomy, and it was all these things, and her sisters and aunts, and nobody talks about it. You know, it's just kind of one of those things, and oftentimes they don't know why, you know, they had hysterectomy or certain, you know, conditions. So I think we are getting to a place where we are more open about it, and it's because of like the advocacy and the things, you know, happening. And now we're talking about gynecologic conditions, and we're studying gynecologic conditions, and we're realizing, you know, it's not just something we have to suffer. That actually has impacts on our life, on our health, on, you know, our livelihoods, and, you know, and everything like that. So I hope it's real, that, you know, that aspect of not talking about it, but I think we are starting to talk about it more.
I have one last question. Is there anybody else with a question? Oh. Angela, is there one in the chat? Nope. Oh, come.
Hi to the panel. Excellent presentation and very informative. And Dr. Porter, you mentioned Jamaican-born women in terms of health outcomes. Did it make any difference as to when the person came to the United States, whether as a child or adult or older?
That particular study didn't go into that detail, and even to find any study that digs into it that deep was hard to find. And I think now that we are understanding more about the intersectionality and subgroups, that more people are doing more studies like that. I mean, I know from the maternal health aspect, we've been doing, trying to understand that differentiation, how long they've been within the country, and having certain outcomes. I don't know if anybody's actively doing that, at least within gynecology, but certainly that is the next step to be able to go deeper. You know, now we know that there is this disparity. Is there a difference based on, just as you said, how long they've been in the country, and, you know, and other, you know, socioeconomic factors.
Thank you.
Okay, one last question. Want to give folks 10-minute break before the next session?
Okay. And my question is regarding high blood pressure. A lot of time we got patient with elevated systolic blood pressure, and sometimes we have patient with diastolic elevated. But we have a lot of controversy. People said in terms of risk factor for stroke or cardiovascular disease, in your experience, doctor, is there any differences? Like if I have elevated diastolic blood pressure, I have more risk for cardiovascular disease or for stroke, or if I have systolic, is there any differences in terms of risk factor for these diseases?
So most of the studies that I showed you, the SPRINT trial, which was the large US trial, the Chinese trials, looked at systolic. That's because once you get past middle ages, 55 into the 60s, 70s, the systolic goes up, the diastolic goes down. So diastolic is a risk factor in younger persons, but age in itself is a powerful predictor of disease. So for most of the big studies now, we're looking mainly at systolic. The idea that if you lower the systolic, you'll lower the diastolic too much doesn't really seem to be a problem, because the systolic, where the pulse pushes the blood and then the diastolic runs off very quickly and you have a low diastolic, they call it a pulse pressure, that seems to be the main predictor of risk. And that's regardless of where you are in the world. We talked about recent immigrants from other countries. It appears that people who come to the United States and they lose some of their connectiveness to prepared foods from their home often do worse when they start eating some of the American foods, the Southern diet, the foods high in sodium. So, quick answer to your question, mainly systolic in older persons, middle age and older, diastolic younger persons, but because age is such a powerful predictor, the studies really look at systolic.
Thank you all for an excellent panel. Appreciate you. And we'll take a 10-minute break and then start again.
All right, thank you.